Welcome to ASA Central Line, the official podcast series of the American Society of Anesthesiologists, edited by Dr. Adam Stryker.
Welcome, everyone, to the Central Line podcast. I'm your host, Dr. Zach Deutch. This month, we're going to be joined by January's guest editor, Dr. Mohammed Rafique, and his editorial co-author, Dr. M-Irfan Suleman, to discuss pediatric regional anesthesia. Gentlemen, welcome to the show, both of you.
Thank you very much. It is awesome to be back.
Now, Dr. Rafique, as you allude to, we know you've been here before. Dr. Suleman, this is your first time. So I'd like to hear from you first. Just tell our listeners a little bit about yourself personally and your professional practice situation.
Thank you so much. And it's a great honor to be on this podcast. I'm a pediatric anesthesiologist and pediatric pain physician. And over the years, my work has shifted more and more towards the pediatric pain. I trained for pediatric and adult pain management at Harvard, and then spent almost a decade at Johns Hopkins and Kennedy Quaker Institute, built and led the pediatric pain program. Right now, I'm in a private practice in Rockville, Maryland, where I lead the multidisciplinary pain center. And honestly, it's not a private practice for business purposes. I'm in a private practice because I am building something I have dreamed about for years. And it's a unique, non-narcotic, multidisciplinary pediatric pain rehabilitation center that I call the Pain Resort. The idea is that it functions like a hospital, but look like and feel like a kids-friendly vacation resort. It will be a place where children in the pain can actually enjoy being there, while other multidisciplinary team work to help these kids back to the normal life. And this is the mission of my life.
I'm Dr. Rafique. I recently was at Loyola University Medical Center. I still have an affiliate professor position there, and right now I am a pediatric anesthesiologist at Advocate Children's Hospital in Oakland, Illinois. And I do acute pediatric pain and regional anesthesia as part of my clinical practice.
Okay, so both of you have understanding of, experience with, an immediate connection to pediatric pain and regional anesthesia. Is that correct?
Correct.
Yes.
Wonderful. Okay, gentlemen. So those introductions are interesting, and I'm definitely interested to hear more, Dr. Suleman, about this venture that you've described for a pediatric pain resort. But let's go back to give our readers sort of a place to start here. The January issue of the Monitor will just talk about regional anesthesia in neonates and small children. So you guys, as experts, can talk to us about the history of pediatric anesthesia. And also, this kind of seems aversive, but used to be widely held idea by earlier generations that young children, such as infants, don't perceive pain. So talk about that, Dr. Suleman, and how did that shape the subspecialty of pediatric pain, please?
Sure. Honestly, it's horrified to look back. For a long time, it was believed the infant and the children don't feel pain the way adults do. The thinking was their nervous system was immature and the pathway was not fully myelinated, and therefore the pain signal could not really travel. People also assumed the infant could not form lasting memory, so even if it's hurt, they won't remember it. And their behavior in response to pain, like crying or agitation, were considered a reflexive, not actual pain. And another big piece of it was fear the anesthesia in the past was risky. And so the mindset was that anesthesia might hurt more than the surgery. So opioid was avoided and or used in a tiny amount. But once the real research started, everything flipped. We learned the babies who went through the painful procedure without anesthesia had a massive stress response, huge cortisol surge, adrenaline spike far more than the adults. And we learned the babies who experience uncontrolled pain early in their life can actually develop long-term changes like a highly pain sensitive, develop anesthesia, and even change in their stress regulation. And that can lead to development of central sensitization, and in the later age they develop a chronic pain. So things change by realizing the infant absolutely feel pain, and with the better safe anesthesia and advanced monitoring, safe drugs, and another important thing is dedicated pediatric anesthesia training. Now we can handle the kids much better.
Okay, so That does sound pretty gruesome what you describe, and it's nice that we've progressed past that. Talk about where we are now. We're more enlightened, we understand these things better. So how do we approach perioperative needs of pediatric patients at this point in time?
So change has been huge. Today we look at the pediatric anesthesia at something much more holistic. It's not just about keeping a child asleep during surgery. It is about protecting them from emotionally, developmentally, and physically. In the preoperative area, we start with a thoughtful preoperative assessment. We modify anesthesia to the child age, health, and psychological need. Adequate pain control is a standard for every age, including newborns. We use opioids when we need to with the modern monitoring. They are much safer. And now we rely heavily on the regional anesthesia and multi-modular strategy for good pain control and to minimize the complication. And thanks to the advance in pediatric anesthesia training and technology, the anesthesia-related mortality in children has dropped to incredibly low in a specialized center.
So, Dr. Rafique, can you expand on that a little bit, or maybe even throw in some of your own observations from your clinical practice over the past decades of the way we approach kids in procedural areas has changed?
Of course, thank you very much. Yes, with the passage of time, pediatric regional anesthesia and acute pain control has progressed a lot. Now, the pediatric anesthesiologists and pediatric anesthesia acute pain teams usually have a multidimensional approach where they have surgery teams on board and they understand that these children need much better pain control. With the passage of time, regional techniques have evolved, and now almost every child who is getting a surgery where a regional technique can be applied, it is being done usually. Now, kids are receiving regional blocks for almost every surgery where a block is possible because surgeons understand better, parents understand better, and the providers are more motivated and more trained and more interested to control the pain as a whole thing.
Okay, that's helpful. And what I want to do now is I want to get into the specifics. And Dr. Suleman, this is going to be for you. I'm going to have a few rapid fire kind of questions. I'm going to list them for you, and I want you to try to touch on each one if you can. I think, as Dr. Rafique said, we know that regional anesthesia is beneficial for patients and certainly for pediatric patients. So let's talk about the current state of regional anesthesia. What blocks are being most commonly done? How are they being done? Are they being done outside of academic and specialized centers? Those are kind of three questions I have for you. If you can touch on all those, I think listeners would really appreciate.
So technology, I will say, completely transformed what we can do, especially with the ultrasound. And the ultrasound regional anesthesia is a totally game changer. We literally see everything like nerve, muscles, fascia, vessels, and the needle tip all in a real time. And because of that, we can able to do nerve block, whatever nerve block we want to, and even we can do in a tiny infants very safely. And because of this technique, the kids have experiences less physiological stress, which is incredibly important. And kids need a very fewer opioids. They wake up smooth, better pain control, and the families are happy. We can do any kind of a nerve block because it's very safe to do with ultrasound. The issue was the toxicity, which is also minimized almost zero because now we don't volume dependent. We see the nerve, we inject it, and we see the good spread, we stop it. We don't need to inject a big volume. When we are doing a blind anesthesia, that was not a good idea to do it because the high risk to have a toxicity. So now even we place the continuous catheter in the young children's and for which allow days of excellent pain control with the minimum medication or almost no narcotics. So regional anesthesia become one of the most powerful tool for supporting healthy recovery and reducing the overall physiological stress of the surgery.
Okay, so sounds like you're doing all sorts of things and you're using ultrasound to help
Yes.
you with the safety profile.
Yeah.
My question would be as a follow-up, I assume these are almost all of these things being done under general anesthesia number one. And number two, is this realistically happening outside of specialized centers or academic centers?
No, not every center, because other than academic centers, they are not comfortable. And as I said, like the most important thing is a pediatric anesthesia training. If they are pediatric anesthesia trained, yes, they are comfortable to do it. At this point, I don't know about the outside the academic center, how many pediatric anesthesiologists are trained, but academic is mostly. Yes, if you are trained, pediatric anesthesia and regional anesthesia trained, yes, you can do it. If you have all the protocol and the safety things, yes, you can do it in other centers. But I was not aware how many non-academic centers are doing a regional anesthesia at this point in the pediatrics.
Okay, so we'll stay on the subject of these specialized centers because, again, most specialized pediatric care, for reasons you guys have both described, is given in these places. So one of the things that centers might do is establish an acute pain and a regional anesthesia service specifically for kids. Talk to us about the benefits of doing that and barriers, problems that might arise in trying to get that accomplished.
The benefit, definitely, I just mentioned all these like less complication, less narcotics use, minimum anesthesia. So, which is all the benefits and good outcome of the surgery. Families are happy. That is the most important, because every family, when their kids is going for the surgery, they are very anxious. What gonna be happen after the surgery about the pain? And imagine when their kids having a regional anesthesia and after recovery, when they wake up and they don't feel pain and they're having a popsicle. So that is so satisfactory for the families. And that also, as an anesthesiologist and surgeon, is so good for them because the patient wake up was so smooth. So this is very important. And yes, this kind of a service actually most of the hospital needs to adopt. And we need a team approach to have these kind of a surgeries. Like we need to be involved the hospital leadership, anesthesiologist, surgeon, and the nurses. And everyone has to buy into this vision that this is an important thing. Pain management, perioperatively pain management is very important. And if everyone is on same page, then we can have that. The most barrier you mentioned, like the surgeon have some concern about, will this block slow down my schedule? Honestly, with the good communication and efficient workflow, these issues go away quickly. And if we have a trained regional anesthesiologist or pediatric anesthesiologist with the regional anesthesia training, and we have a 24/7 availability of this team, and we have a clear protocol so everyone knows what to expect, that will help a lot to be build this service. And other barriers, like definitely, as I said, the training, resources, and the culture shift. But every one of these have a solution. Once the service is running well, the impact is enormous. In pediatric, where the comfort and the long-term outcome matter so much, regional service really is not a luxury. It's an investment in quality of care.
Okay, so I have a question for each of you, and they're different questions, but I think they're very important. The first thing I want to ask Dr. Suleman is, you did mention in your intro about the venture that you're involved in with pediatric pain, and I would really like to hear more about that, and I think our listeners would as well. Talk to us not just about the philosophy, but the implementation and the specifics of this pediatric pain center that you want to create, please.
Thank you for asking this question. Pediatric pain is my passion. Pediatric pain is my baby. I really very much involved in this. I do also pediatric chronic pain. If the pediatric acute pain is not well managed, they can develop into the chronic pain. When I see these patients with my multidisciplinary team, and when I was in Johns Hopkins for a decade, and I have a team with the pain physician, psychologist, psychiatrist, physical therapist, and social worker. So we all as a team see the patient for a couple of hours, and we dig into the factor which contributing and amplifying the pain. And you will be amazed when we go from the birth history till now, the patient who have an experience of the pain, we find this patient have some underlying issues, some underlying stressor, and have a multiple experience of the pain in the past which was not well managed. And with the combination of these factors, now they have significant chronic pain, which is not getting better. Physically, when they go to any specialist or any have MRI and X-ray, everything look normal. But they have experience of the pain that affecting their daily life, that affecting their school, their social life, sports and everything. They are isolated. Now they are behind from their school and from peers. Now they feel anxious, they feel depressed. That further amplify. So with this team approach, we identify all these factors and targeted all these factors simultaneously. When you treat simultaneously as a team approach, that help to reverse even whatever complex patient it is. I have seen a several patient in last 1 decade which is impossible to reverse, and they have actually seen a multiple physician and multiple specialty, and no one have an answer, but we have an answer and we treat and bring them back to the normal. Unfortunately, all the specialities, any specialty, they are not trained to handle the pediatric chronic pain. So that's why the pediatric chronic pain training is also very important to understand and reverse it. More quicker you reverse is better. More is delayed is get more complex and complicated. But I will say even if it's a complex or complicated, it's reversible. That is my passion. So at this point, unfortunately, in the whole country, we don't have any full service. Like we have some hospital who are providing these services, but we should have one kind of a service which have everything under one roof. When I say like a pain resort, number one, we don't need to be a hospital environment. When these kids in a chronic pain, they should not treat it like as a patient like other who have some diseases going on. So they are going through some situation. So number one is if you're bringing in a hospital is a white coat syndrome, they are traumatized with this environment. So I feel like they should have some resort vacation which they enjoy it and want to be there. Plus we have all the provider under one roof. Referring to the patients to other specialties, psychology, psychiatrists is always have a communication gap. So that communication gap does not help to reverse this. So if you have under everything, plus this facility, the pain resort will help to provide outpatient services, day programs, and the inpatient services, which is going to be a unique resort in the country, I will say in the world. So that's my vision or mission of my life.
Okay. And just so listeners know, is there a website or another place you could go to get more information about this?
Yeah, this is just new. We also have a Pediatric Pain Foundation, which is a 501c. That is the foundation help to build this facility. Right now, we are very early stages, but the website is the pediatricpainfoundation.com, and that can be under. Plus, my also personal website is a multidpain.com. That gonna be all the information under these two websites.
Okay, wonderful. Now, Dr. Rafique, turning to you, we've heard quite a bit there. I want to get a more general view from you. You understand the care of children and perioperative care and procedural care. What do you think we're going to see in the future for perioperative care of children as relates to pain or as does not relate to pain?
I think, as Dr. Irfan has alluded, that a lot of times children who experience pain which is not treated may get some chronic changes in their brain and the nervous system, which could lead to future problems. With more and more awareness, pediatric regional techniques have come a long way, and now they are very practical and they are being practiced by clinicians both in academic and also non-academic but large pediatric centers, where pediatric pain is being controlled and treated by using regional techniques, including pediatric and infant neonatal spinals, pediatric regional blocks, and pediatric neuraxial blocks other than spinal. All these things are becoming more and more common, and parents who are a very, very big stakeholder in care of their children, they now understand that whenever somebody is talking about putting a needle in and giving some numbing medicine, that is something which is going to help their child, not to hurt their child. So they are more prone to accept regional techniques. Still, there is more and more education needed at the level of the community, at the level of the parents, where there is some research now which shows that sometimes minorities and some population groups usually have a aversion from regional techniques. Like they say, if a child of color, their parents may not accept a caudal block, which is one of the oldest block which is practiced in pediatrics as a regional technique to control the pain. So more and more awareness at the community level, at the parents level, and more advocacy by pediatric physicians and hospitals and health systems is happening, and more needs to happen, and all those things are going to be helpful for controlling pain in children.
Okay. You've both made a strong case for advocating for our younger patients and moving to a new era of perioperative care, which I think is a very admirable thing. And I'll be interested to see how this develops. We've coming to our end here. And Dr. Rafique, you have the honors of our last question. Since you were our guest editor for January and you're an esteemed member of the editorial board. So tell us what else is in this issue of the Monitor that would be of interest to readers and listeners. What will they learn and what will be enjoyable for them to see in print?
Most definitely. My goal while putting together this issue was that I bring everything which probably could help the clinicians, our ASA readership, which they could need and use to promote pediatric regional techniques and be able to practice pediatric regional techniques. So, two of those articles are to tell us how to establish a service for regional anesthesia and pediatric spinal anesthesia, and what tools they will require to create this service. Another article encompasses what is the role of workshops at national meetings which teach pediatric regional anesthesia, how they are helping and how those can be made better, and what is their significance. Another article by Dr. Corallo highlights that the oldest pediatric regional technique, which is caudal block. He has a small review, but the most important thing is that how to develop a teaching tool, a ultrasound friendly model to teach caudal block to others from scratch without spending thousands of dollars. And I think that is a very well written article. And the last article in this issue is regarding how the pharmacology for local anesthetics is different in neonates and small infants. And I think these articles will, one, highlight the current issues which could be people facing, and also bring more awareness to the clinicians how to implement these regional blocks in their practice and how to help their patients.
Okay, excellent summation. And so for listeners and then eventual readers, there's something to get you through your post-holiday letdown as you can read that January issue and learn so much stuff and think about how to help people that really need to be helped that have a harder time speaking for themselves. Gentlemen, it's been great having both of you here. I've really enjoyed speaking with you. I think this was an excellent topic, and I see a lot of humanitarian and scientific and medical and some good work to be done to help people that, again, have trouble finding a voice. For listeners, thank you for tuning in to this episode of Central Line Podcast. Please join us next time. And remember, you can always go to asamonitor.org for more information. Take care for now.
Thank you.
Thank you very much.
Every day gives you new reasons to say yes to ASA. Explore all member benefits, renew now, or join today at asahq.org/benefits. Subscribe to Central Line today, wherever you get your podcasts, or visit asahq.org/podcasts for more.